breaking news. More positive news stories about semaglutide. Sorry, what? That's not how I meant to say it. How am I meant to say it? Semaglutide? Is it T-I-D-E? Tide? I mean, that doesn't make much sense. Semaglutide? I mean, do we know if that's right? Does anyone know if that's right? Someone from America. Semaglutide. I can't say that. Firstly, we're in Britain. Secondly, I'm not sure that accents are okay. Well, okay, just use the brand name. Okay, look, let's just use. Okay, breaking news. Positive news stories about Wegovy. So, sorry, what? That's not right either? I mean, that's literally how it's written. You think it's Wegovy? Wegovy? Ah, this is ridiculous. Why can't they just call these medications something like Brian? Give yourself a once weekly injection of Brian. Good news, it's going to help you lose weight. Bad news, you're probably stuck with Brian for the rest of your life. What's that? You want to try a bit of Derek? Yeah, you would, wouldn't you? It's Friday, the 17th of May, and this is the Hot Topics podcast. Hello and welcome to the Hot Topics podcast from NB Medical. Neal Tucker here once again to take you through some of the latest research that's published relevant to us in primary care. As usual, just a quick bit of NB Medical news to start off with. We have 3 new courses. So one's just happened, that's our cardiology course. So if you want a bit of an update on the latest information in cardiology, and if you want a really good refresher on ECGs, then check out our cardiology course. You can find it on demand on the NB Medical website. Then, soon to come, we've got our new men's health course. So this is a live webinar on Thursday, the 6th of June. It's a morning half-day course. And then shortly after that, we've got the palliative and end-of-life care course. That's on Thursday, the 27th of June. That's another half-day morning course. If you can't make it on those days, don't worry. Shortly afterwards, it will be on demand as well to watch at your leisure. So do check those out. Don't forget, of course, if you are subscribed to NB Plus, you can come on all of these live webinars and watch everything on demand, all as part of your subscription. While I think about it, this week I've been spending a lot of time recording some of the latest Hot Topics takeout. So this is where we do a podcast style of the latest Hot Topics course. All of the new topics covered and some that we couldn't fit in the actual presentation on the day itself. It's great if you're spending a lot of time commuting, walking the dog, going to the gym, or you just want to casually to have a listen to something in the evenings. Join us with the Hot Topics takeout. So that'll be on the nbmedical.com website in the next week or so. Quick little section on the news, and same kind of stuff going on. Let's be honest, contract disputes in England, not enough money to fund services adequately anywhere, new mixes of healthcare staff, which we're just getting our heads around how that's all going to fit together. GPs in some parts of the country struggling to find work, possibly as a result of the aforementioned. I feel like I've talked about a lot of this stuff ad nauseum, so let's not rehash it today. I was interested to see such a big report on semaglutide come out in the popular press this week. This is the report from a UCL-led research team that says the weight loss drug can deliver cardiovascular benefits in people who have got established cardiovascular disease, irrespective of their starting weight and the amount of weight lost. What most surprised me was that it seemed to be billed as new news, but this is actually a re-examination of the data in the SELECT trial that was published last year. This was the trial on semaglutide and cardiovascular outcomes in patients with established cardiovascular disease. It showed a 1.5% absolute risk reduction in a composite endpoint of cardiovascular outcomes, including mortality, MI, and stroke. Interestingly, none of those components individually met statistical significance. Only when you're looking at the composite, that all of them together, did it meet that threshold. Nevertheless, I think in the context of lots of cardiovascular interventions, they may argue that that's actually considered still quite an important marker. And even though it doesn't sound like a huge absolute risk reduction, that's also in line with many cardiovascular treatments that we use on a regular basis. Anyway, this new research isn't actually published yet. It's just they've done a press release because they're at a World Obesity Conference. And clearly they've got a really good comms team, just in case the world needed even more exposure for semaglutide. Now, we've been presenting on the latest Hot Topics course about semaglutide, so check that out if you're interested in seeing some of this research, including the SELECT trial. But if you want to know a lot more about it, really worth having a listen to the podcast Diary of a CEO with Johan Hari. He's a journalist and author, written very popular books on addiction and depression before. And in his latest book, he describes his experience of semaglutide and then what he's found out about this drug and the related medications that we're going to see loads of over the next few years after he's gone and chatted with lots of experts around the world about it. On to the research then. And today we've got 4 or 5 maybe different papers that I want to cover. Most of them come from this month's BJGP, which was a fascinating read. And I'm not necessarily going to cover those papers in like huge detail, but bring out the themes from them. And then we're going to cover a paper from the BMJ on what may be the best oral drug for people with type 2 diabetes after metformin. So the BJGP, it feels like they've really nailed the topical aspect of the journal this month. It's entitled Workforce. Doesn't get much more topical in British general practice than that at the moment. And there's lots of research in here that was absolutely fascinating. So, of course, we all know the challenges. We've got financial challenges. We've got the challenge of new groups of staff and how they integrate into general practice. We've also got just relentless change, and that's hard to deal with as well. So let's start with paper number 1, which is their top of their list in the journal. And the title of this is Does Shortage of GPs Matter? A cross-sectional study of practice population life expectancy. In the abstract under background for this paper, they say, there are not enough GPs in England. Now, you could do a whole podcast just on that one sentence. Not everyone would actually agree with it, although most people in their day-to-day work might be feeling that way. Then they go on to say access to general practice and continuity of care are declining. And the aim of the study was to investigate whether practice characteristics are associated with life expectancy of practice populations. So the idea underpinning this is that life expectancy had improved for many years, many decades. In fact, life expectancy has been going up and now it has stalled. And so one of the questions that they're posing here is how much can general practice influence life expectancy in our populations? If there was a theme for me in this podcast today, it would be study designs that I don't really understand. So we're going to see many of those in the coming papers. But in this one, it's described as a cross-sectional ecological study between 2015 and 2019. They had 3 hypotheses that they wanted to examine. So they were that increased life expectancy is associated with 1, an increased number of practice staff, number 2, improved access and continuity, and 3, better clinical care in practices. To do this, they picked 16 different independent variables looking at various aspects of practices and its population. So, for instance, they looked at population characteristics like deprivation, ethnicity, and specifically they were looking at percentage of white population at a practice. They also looked at diabetes, the rates of diabetes. Practice organisation was the next big theme, so full-time GP equivalence was the big one to look at there. Also, they looked at the role of other staff like registrars, ANPs and receptionists. They looked at nursing staff independently, so nurses minus ANPs, and also total payments to practices per patient. They looked at access, so how many people are seen on the day, and then they looked at clinical performance, so a number of QOF markers, such as ones for vaccinating people with COPD and meeting diabetes targets, and then also continuity. They examined this in practices in England with life expectancy data from the National General Practice Profiles system. That's a new one on me. You at home are probably very familiar with this. You have chats with your mates about it down the pub over a pint. Lots of results to unpick with this. Firstly, deprivation and living in areas outside of London were strongly associated with a poorer life expectancy, particularly if you live in the Midlands and in the north of England. Factors associated with greater life expectancy included having more full-time equivalent GPs at a practice. Now, having other staff, so again, they looked at GP registrars, ANPs, and receptionists. So this is not something directed at the ARRS staff, this is generally speaking. Other staff didn't influence life expectancy. However, the presence of more nurses at a practice was associated with lower life expectancy, and the authors felt that this probably reflected if you have a more deprived population, they're usually going to need more nursing input. Practices will need to be employing more to meet that care demand. They also found that better access and better continuity were also associated with greater life expectancy. They also found, interestingly, that 2 out of 4 of the QOF markers they examined, so percentage of patients with diabetes in whom their latest HbA1c was under 59, or percentage of patients with COPD who had influenza immunisation, they found higher rates of achievement on those targets led to improvements in life expectancy. And they were a bit surprised by this, considering that, as we've talked about on the podcast before, we don't have data showing that QOF actually improves longer-term outcomes for our patients, which still baffles me and leaves me deeply troubled. The authors conclude that the number of GPs, continuity of care and access in England are declining, and this is worrying because these are features of general practice that are positively associated with life expectancy. What this paper also shows us is that the biggest influence by far on your life expectancy is where you live. This brings us on to our second paper in the BJGP. So this one's all about PCN networks in England. The title is Exploring Whether Primary Care Networks Can Contribute to the National Goal of Reducing Health Inequalities. And actually, the reason I wanted to present this one was not because the sequential mixed methods study of PCNs in England, whatever that really means, has practice-changing implications for you and I, because I don't think it does. It may have practice-changing implications for policymakers, but on the ground, it's not going to immediately influence what you and I might do. But the reason this paper stood out to me was just this idea about health inequalities. And I must admit, maybe I'm completely getting this wrong, but it really, really frustrates me. I feel like we're constantly told that healthcare professionals and general practice should be improving the nation's health inequalities. It's a relentless message. You get it in all the journals all the time, policymakers constantly laying this on us. And I'm not saying it's not important to try and improve on health inequalities. It obviously is. But I just feel like it's gaslighting healthcare professionals. Let's be honest, as our first paper has just shown, other factors are very important here. Housing, education, employment opportunities, adequate social support when it's needed, provision of good social care. These are the biggest drivers of deprivation, and these are the best ways that you can improve on deprivation if you can address them. So telling us in general practice to improve health inequalities is a bit like us pissing in a fire when there's a fire engine right behind us, but they won't turn the hose on. So don't blame healthcare for health inequalities. Blame successive governments, blame the world global markets, blame an aging population, whatever you want to, but don't blame healthcare. We're the ones trying to sort it out. But it is true, as the last study shows us, and as I'm sure lots of other research shows us as well, that we can make a bit of a difference in some parts. But to do that, you need resources, and for resources, you need money. Core funding has been going down and down, but of course, in England, at least, we've had the introduction since 2019 of PCNs. And the aim of this second study was to consider how the design and introduction of PCNs might influence their ability to tackle health inequalities, starting by looking at the amount of funding coming into each PCN relative to the level of deprivation in their practices. So they compared the first year of PCNs, 2019-20, to more recent data in 2022 to 2023. And they found in more recent years, deprivation resulted in more funding. Strictly speaking, I think that sentence is true, but if I understand this data correctly, deprivation actually results in lower funding per patient. It's just by 2023, it was less lower funding. The authors are clearly trying to be relatively positive about this. I just found the whole thing a bit depressing. The authors concluded allocated PCN funding has become more pro-poor over time, suggesting the need to account for deprivation within funding models is understood by policymakers. Yeah, sure, let's go with that. They then say that the following additional approaches have been highlighted that could support PCNs to tackle inequalities. So better management support, encouragement and support to redistribute funding internally to support practices serving more deprived populations, and greater specificity in service requirements. There's a lot of management speak there. You can tell I should never, ever really go into any kind of management role, because I just think, well, maybe if we just made people have less heart attacks or helped them give up smoking, or indeed just took all that money and just gave it to the people who are living in deprived areas, then that might actually make a bit more of a difference than having a few more meetings. Screaming on to paper number 3, and this is about continuity. Continuity, that's been a big buzzword for the last year. Continuity is being shown to be good for patients. But as more GPs are like me, who can't be bothered to go and do the real job for more than a couple of days a week, continuity is becoming increasingly challenging. To try and justify this, policymakers, and maybe to try and make ourselves on the ground feel a little bit better, we've grabbed onto the idea that you don't necessarily have to have just one-to-one continuity. So relational continuity, it's called, where you have a one-to-one relationship. You have your healthcare professional and your patient. But instead, you can have continuity shared as a practice, particularly with shared record keeping. Now, I was briefly a partner. I spent years as a salaried GP. Currently, I'm officially a locum. And in this role, it's true that most of the patients that I see in a session are patients I've never met before. And it's hard dealing with these patients, because you're going from absolutely nothing and you're trying to understand years of medical history, all the things they've tried before that different healthcare professionals have done for them before, what's worked, what hasn't worked, where they are now, what the patient actually wants rather than what we think maybe they should have. A lot of this you can get from the notes, not all of it, but a lot of it you can. But it's really time consuming. If you want to do it well, it's time consuming. This is what I tell myself when I'm relentlessly running late and going home much later, it would seem, than many other doctors in the practice. Yes, I'm fully aware that maybe I just talk too much. Anyway, it's either time consuming to get up to speed on a very thorough level with these patients, or you're essentially skimming the surface. And if it is a complex patient, then I could easily see how it may have detrimental consequences. Most importantly for the patient, but also potentially for the practice or the wider healthcare system. So the title of this paper is Factors Affecting the Experience of Joined-Up Continuous Primary Care in the Absence of Relational Continuity, an Observational Study. The authors conducted case studies in 2 extended access providers in the north of England. And I think they deliberately targeted these organizations rather than your standard in-hours general practice, because this is where that continuity can really break down. It's also very topical because it's a concept that's being pushed through PCNs, and also very topical because, of course, there are some ICBs in England that are trying to separate out acute and chronic care, and that further deteriorates the relational, that one-to-one healthcare professional-patient relationship in favour of broader systems continuity. In this study, the two extended access providers that they were examining, it appears that they had access to 30 of their own notes, but also potentially access to the patient's practice's notes, maybe their appointment system as well. That might have only been if the clinician happened to be seeing a patient who happened to be from their practice. Anyway, they undertook this assessment through observing patient-clinician interactions, interviews with patients and clinicians, and also examining the documentation afterwards. I think the paper is open access, and of course the link to it is in the podcast description. It's worth going and having a read of some of the examples that they give, because this is a nice example of some qualitative work. But to cut a long story short, they conclude healthcare systems increasingly rely on the assumption that any competent clinician can deliver joined-up continuous care if they have access to clinical notes. This appears not to be the case. They highlight it's dependent on a range of factors: staff, patient, and system. And they point out that even despite multiple initiatives in place to try and improve patients' experience of continuity, such as clinicians having access to patient notes, electronic messaging systems between practices, they say that isolated intervention, however well-meaning, is often not enough to enable a patient to experience joined-up seamless care. They suggest that in these extended access services, so we're not actually talking about out of hours here, we're talking about in hours, but where practices are overwhelmed by patient demand, and so patients need to go into some other kind of system. And a common pathway that they pointed out here is that the practice has no appointment, so patient phones 111, that puts them through to the extended access service. But as the authors point out, perhaps triaging patients so that those with more complex issues are dealt with in their registered practice, that could be a good idea. Recruiting staff members who work in local daytime practices, that could potentially help. Of course, you're potentially robbing Peter to pay Paul there. I guess all of this just highlights the challenges. They also say that further studies for in-hours general practice would be good. And indeed, that brings us on to study number 4, which talks about exactly that. So this is continuity and breaches in GP care and their associations with mortality for patients with chronic disease, an observational study using Norwegian registry data. And I'm going to be really quick with this one, because essentially this just confirms our previous point. This shows that in patients with COPD, with heart failure, with diabetes, all are associated with lower mortality if you get to see your own named GP more often than you see your not named GP. In a system where it seems to be a drive towards GPs overseeing other healthcare professionals, in a system where there are GPs who seem to be struggling to find work, you really hope that this kind of information gets through to those policymakers that are designing general practice contracts. Okay, paper number 5 today, and this is in the BMJ this week. This is Comparative Effectiveness of Second-Line Oral Anti-Diabetic Treatments Among People with Type 2 Diabetes Mellitus. You decide. So, SGLT2 inhibitors. They seem to be good for everything. Heart failure, kidney disease, of course, diabetes, athlete's foot, just crush them up and rub them on it. Maybe that'll work. I don't know. But it's surprising that in the management of type 2 diabetes, at least in the current NICE guidelines, that they're only top of the list after metformin, of course. That's still top of the list. But they're only top of that escalation strategy list if you have established cardiovascular disease. Otherwise, it's still gliptin, sulfonylurea, or pioglitazone. unless you have an increased risk of cardiovascular disease, in which case NICE says consider an SGLT2 inhibitor, that ever slightly unhelpful phrase. All of this uncertainty is because there's been a lack of evidence on comparative effectiveness, which this BMJ paper looks to redress. Apparently, to quote the authors of the paper, there have been recent advances in real-world data combined with developments in quantitative methods which offer important opportunities for generating evidence on comparative effectiveness of treatments with direct relevance to clinical practice. Sounds good. So they then used cohort data to, as they put it, emulate the design of a hypothetical pragmatic randomized controlled trial comparing 3 anti-diabetic drug classes. Whoosh. Tumbleweed goes past, Neil scratches his head. See what I mean about study designs? Deep down, I have a dislike, admittedly born out of ignorance, but a dislike of complex research practices as they feel very opaque to the outside observer. Anyway, it's in the BMJ, and almost every author is a professor, so I'm assuming this is all legit. They included data on 76,000 patients in England between 2015 and 21, all who had type 2 diabetes and were given either as an SGLT2 inhibitor, a sulfonylurea, or a gliptin. The primary outcome was change in HbA1c at 1 year follow-up, and then they had a range of different secondary outcomes, including change in BMI, blood pressure, eGFR at 1 and 2 years, also HbA1c at 2 years, and then also rates of heart failure and MACE, so composite endpoint of cardiac mortality or events. And the results showed that the SGLT2 inhibitors came out best in most metrics. So it was the most successful at reducing HbA1c compared with the other two. It had a greater reduction by 2 to 3 millimoles per litre. BMI and blood pressure were lower. Heart failure admissions were much lower. Maybe no surprise given we have that research now on SGLT2 inhibitors in heart failure. Also, decline in eGFR was much lower with SGLT2 inhibitors. Likewise, we've got separate data that shows that too. We might have assumed that they would lead to lower heart attacks and stroke, but actually this data didn't show that. I think some of that is because there's a lack of data in this area, but also in the other studies, they seem to have demonstrated that most of the cardiovascular gains with SGLT2 inhibitors seem to be linked with heart failure rather than atherosclerosis. Anyway, in conclusion, you have a patient with type 2 diabetes who's not meeting their targets on metformin alone. You're wondering what drug you should escalate treatment with. NICE says consider if there's a high risk of cardiovascular disease, which includes patients who've got a 10-year cardiac risk of 10% or greater. Seems to me that probably all patients with type 2 diabetes are going to meet that criteria. Well, rather than considering, it might be better to just give them an SGLT2 inhibitor unless there's some contraindication. Phew, nice to end on a piece of research that actually might make our lives a little bit easier, as well as making our patients' lives that little bit better. So thanks for joining us on the podcast today. As ever, you can get in touch, so you can email hottopics@nbmedical.com. Find us on social media as well. Don't forget to check out the fantastic new courses that we've got coming up. And actually in June, we've got so many courses going on. We've got all of our normal courses as well. So if you're looking to upskill, you want to stay as up to date as possible, or you just want to do a bit of CPD, then do check that out. And don't forget, you might as well sign up for MB Plus as well. I'll be back in a few weeks. Look after yourselves, everyone. Take care. Bye-bye.